You stand at the pharmacy counter. The fluorescent lights hum overhead. You hand over a plastic card, and a transaction occurs that defies every traditional law of supply and demand. The pills in the amber bottle cost $12 to manufacture. The pharmaceutical company set the official list price at $500. You pay a $50 copay. The pharmacist receives $40. Hundreds of dollars have just materialized and vanished into a digital void between the moment the prescription was swiped and the moment the receipt was printed. Where did the money go? It was captured by a hidden layer of the American economy. These are the pharmacy benefit managers, or PBMs. They are the unseen architects of the prescription drug market. Health insurance plans hire them for one explicit reason: to control the exploding cost of medicine. They are supposed to be the ruthless negotiators standing between vulnerable patients and greedy drug makers. But an economic contradiction sits at the heart of their business model. Intermediaries hired to control prescription costs can also profit from opaque rebates, spread pricing, and vertically integrated pharmacies.
They are the toll collectors on the highway of healthcare. A small group of intermediaries can now influence which medicines millions of Americans receive, which pharmacies fill them, and how costs are distributed across the entire system. When you hire a corporation to lower a price, you assume their incentives align with yours. You assume they want the price to reach zero. But if the price reaches zero, the middleman has nothing left to negotiate, no margin left to capture, and no reason to exist. The mechanism of cost control has evolved into a mechanism of profit extraction. To understand how the American medical system actually functions, you must stop looking at doctors, patients, and drug inventors. You must look at the administrative layer. You must track the ghost money. The story of the PBM is the story of how an administrative convenience transformed into a monopolistic choke point, rendering the very concept of a price entirely meaningless.
To understand the invisible cartel, you have to rewind to a time before the digital networks took over. In the late 1960s, processing a prescription claim was an agonizing exercise in physical bureaucracy. Patients paid cash at the pharmacy counter, saved their paper receipts, filled out forms, and mailed them to insurance companies. Weeks later, a check might arrive in the mail. The system was slow, expensive, and prone to endless human error. Insurance companies despised the administrative burden, so they outsourced it. They hired third-party administrators to handle the paperwork. These early PBMs were nothing more than data processors. They issued plastic cards, routed electronic signals over telephone lines, and charged a tiny, flat administrative fee for each transaction. They were the plumbers of the healthcare system. But in the 1990s, the landscape of medicine shifted violently. The era of the blockbuster drug arrived. Pharmaceutical companies began releasing revolutionary medications for chronic conditions like high cholesterol, depression, and acid reflux. Millions of patients demanded these daily pills.
The cost of prescription drug benefits exploded, threatening to bankrupt the health insurance industry. The insurers panicked. They turned to their plumbers and asked them to become bouncers. The PBMs realized they were sitting on a gold mine of aggregate demand. Because they processed claims for dozens of different health plans, they represented millions of covered lives. They walked into the boardrooms of the pharmaceutical giants with a new weapon: the formulary. The formulary is simply a list of covered drugs, but in the hands of a massive PBM, it is an instrument of absolute market control. Imagine a nightclub where the PBM owns the velvet rope. If a drug maker wants their new cholesterol pill inside the club, they have to pay a toll. If they refuse, the PBM excludes the drug from the formulary, and millions of patients are instantly blocked from accessing it through their insurance. The drug maker loses the entire market overnight. So the drug makers agreed to pay. They called these payments rebates. On paper, this looked like a massive victory for the healthcare system. The PBMs were using their collective bargaining power to force pharmaceutical companies to offer massive discounts. The health plans were thrilled because their overall drug spending decreased. The PBMs looked like heroes, taming the wild inflation of the pharmaceutical sector. But a historical blind spot began to form. The transactions were completely opaque.
The PBM negotiated the rebate directly with the drug manufacturer. The drug manufacturer paid the rebate to the PBM. The PBM then passed a portion of that rebate back to the health insurance plan, keeping a slice for itself as a reward for its aggressive negotiation. Nobody except the PBM knew exactly how large the total rebate was, or how big of a slice they were keeping. This secrecy birthed a bizarre new economic incentive. In a normal market, a negotiator wants the starting price of a good to be as low as possible. But the PBM's profit was now tied to the size of the rebate. A 20% cut of a $50 rebate is $10. A 20% cut of a $500 rebate is $100. The intermediary suddenly realized that it did not want the list price of drugs to go down.
It wanted the list price to go up, as long as the rebate went up even faster. The pharmaceutical companies quickly understood the game. If they wanted premium placement on the formulary, they needed to offer the PBM a massive rebate. To afford the massive rebate without destroying their own margins, they simply raised the list price of the drug. The list price became a fiction, a wildly inflated number designed solely to accommodate the PBM's required discount. The entire system detached from reality. The PBMs had successfully engineered a market where they could claim they were saving the system billions of dollars while simultaneously driving the foundational sticker price of medicine to unprecedented heights. The plumber had not just become the bouncer. The plumber now owned the building, set the rules of entry, and took a cut of every drink poured, all while convincing the owners that they were saving them money.
Let us examine the exact psychology and financial architecture of the modern rebate trap. The major players in this space are not small administrative firms. They are colossal corporate entities. When you look at the landscape, you see names like CVS Caremark, Express Scripts, and Optum Rx. These entities are not just participants in the market, they are the market. Their motives are dictated by the relentless demands of publicly traded growth. They must show increasing margins every quarter. But how do you increase margins in a market where you do not manufacture the product, you do not prescribe the product, and you do not consume the product? You manipulate the flow of capital between those who do. Consider the life or death decision of placing a drug on Tier 1 versus Tier 3 of a formulary. Tier 1 means the patient pays a tiny copay, maybe $10. Tier 3 means the patient pays a massive percentage of the cost, or is subjected to prior authorization hurdles that delay care for weeks. When a manufacturer launches a new insulin or a new blood thinner, their entire corporate survival hinges on securing Tier 1 status. The PBM executives know this.
They sit across the table and demand concessions. But the concession is not a simple price cut. It is a complex contractual kickback. The manufacturer agrees to refund 50% of the drug's cost back to the PBM after the sale is complete. The PBM looks brilliant to its client, the health plan. They report that they have secured a 50% discount on a vital medication. But the collateral damage of this hidden motive is catastrophic for the end user. The patient with a high-deductible health plan, or the uninsured patient who has to pay cash, does not get the 50% discount. They pay the inflated list price at the pharmacy counter. They are subsidizing the rebate. The PBM's insatiable appetite for rebate revenue creates a system where the sickest, most vulnerable patients, those without premium insurance coverage, are forced to pay the highest possible prices to fund the discounts enjoyed by the massive corporate health plans. The PBMs defend this practice aggressively. They argue that without their tough negotiation tactics, pharmaceutical companies would raise prices anyway, and nobody would get a discount. They point to the billions of dollars they return to health plan sponsors every year, money that helps keep monthly insurance premiums from rising even faster. The incentive structure is perfectly rational from the perspective of the intermediary. They are maximizing shareholder value by leveraging their gatekeeper status. They have convinced the market that high list prices are the fault of the greedy manufacturer, while quietly building a business model that requires those high list prices to exist. If a manufacturer tries to launch a drug with a genuinely low, transparent list price and zero rebates, the PBMs routinely refuse to cover it. A cheap drug offers no spread. A cheap drug offers no kickback. A cheap drug is useless to the entity designed to profit from the discount. The intermediary demands inflation. The rebate is only one engine of the PBM profit machine. The second engine operates in the shadows of the pharmacy counter, entirely invisible to the patient. It is called spread pricing, and it represents one of the most ruthless forms of arbitrage in the modern American economy. When a patient fills a generic prescription, the pharmacy buys the drug from a wholesaler for, say, $2. The PBM, acting on behalf of the health plan, determines how much the pharmacy will be reimbursed for dispensing that drug. The PBM sends a digital message to the pharmacy. We will pay you $4. The pharmacy makes a $2 gross profit, barely enough to cover the pharmacist's time, the rent, and the lights. But the transaction does not end there. The PBM then turns around and sends a separate digital message to the health insurance plan. They bill the health plan $20 for that exact same generic drug. The PBM pays the pharmacy $4, collects $20 from the plan, and pockets the $16 difference. This is the spread. The health plan has no idea the pharmacy was only paid $4.
The pharmacy has no idea the health plan was billed $20. The PBM exploits the asymmetry of information to capture a massive margin on a low-cost commodity. The Government Accountability Office, the GAO, independently documented this exact mechanism, noting that PBMs administer prescription benefits, negotiate rebates, influence drug pricing, and use pharmacy reimbursement arrangements, including spread pricing, to generate revenue. The state Medicaid programs, funded by taxpayers, were losing billions of dollars to this invisible spread. But the PBMs did not stop at algorithmic arbitrage. They realized that the ultimate way to control the spread was to own the pharmacy itself. This triggered a massive wave of vertical integration. The PBMs began buying up mail-order pharmacies and specialized pharmacies that dispense incredibly expensive, complex drugs for conditions like cancer and rheumatoid arthritis. Today, CVS Caremark is owned by the same parent company that owns the CVS retail pharmacy chain and the Aetna Health Insurance Company. OptumRx is owned by United Health Group. Express Scripts is owned by Cigna. The insurer, the PBM, and the pharmacy are now the same corporate entity. The conflict of interest is absolute. The PBM dictates the reimbursement rates for every independent pharmacy in the country, while simultaneously owning the largest competitors to those independent pharmacies. They begin to squeeze. They lower the reimbursement rates for independent pharmacies so drastically that the independents lose money on every prescription they fill. They bleed the local pharmacies dry. At the same time, the PBM uses its formulary power to steer patients away from the local pharmacy and into their own wholly owned mail-order facilities. A patient receives a letter stating that their life-saving specialty medication will no longer be covered unless they switch to the PBM's designated specialty pharmacy. The captive patient has no choice. The independent pharmacy loses its most profitable patients. The PBM captures the entire life cycle of the transaction. They collect the premium from the employer. They negotiate the rebate from the manufacturer. They dictate the reimbursement to the competitor, and they dispense the drug through their own subsidiary. The dominoes fall across rural America, where independent pharmacies close their doors, leaving vast medical deserts. The Federal Trade Commission watched this consolidation with growing alarm. In 2024, the FTC released an interim staff report on prescription drug middlemen. The factual nucleus of their investigation was staggering. The FTC reported that the 6 largest U.S. pharmacy benefit managers handled more than 90% of prescriptions in 2023. Let that number sink in. 90% of the medicine flowing through the veins of the American healthcare system is controlled by 6 intermediaries. The FTC staff documented the extreme concentration, the vertical integration, the formulary influence, and the devastating effects on independent pharmacies. They highlighted how these entities wield enormous power over access and pricing. However, a truth qualifier must be applied here. The FTC findings include staff analysis and qualified language about incentives and potential effects. This does not mean every single PBM contract raises every single patient's price. The GAO documented that PBMs do, in fact, provide a cost control function for many health plans.
They process millions of claims efficiently. They identify dangerous drug interactions, And they do secure lower net costs for many self-insured employers who lack the scale to negotiate directly with Pfizer or Merck. If PBMs provided zero value, the market would have bypassed them decades ago. But the sheer scale of the concentration means that the free market has ceased to exist. When 6 companies control 90% of the supply chain, they are no longer negotiating prices. They are dictating them. The tension between the GAO's acknowledgement of their administrative utility and the FTC's warning about their monopolistic leverage is the defining conflict of modern drug pricing. The idealism of collective bargaining has collided with the reality of corporate consolidation. The barrier between insurer, administrator, and provider has broken down. The PBM is no longer an agent of the health plan. The PBM is the master of the health plan. They write contracts so complex, shrouded in non-disclosure agreements, that even the largest Fortune 500 companies hiring them cannot audit the true flow of the rebate dollars. The system is locked.
The independent pharmacists protest, the patient advocacy groups file lawsuits, the politicians hold grandstanding hearings, but the mechanism grinds forward. The intermediaries have built a fortress out of complexity. They have weaponized the very concept of a discount. And as the vertical integration deepens, the squeeze tightens, leaving patients and independent providers trapped in a labyrinth where the price of a drug is whatever the middleman decides it needs to be to hit the quarterly earnings target.
When you strip away the plastic cards, the digital routing, and the bureaucratic jargon, the story of the pharmacy benefit manager is not really a story about medicine. It is a story about the fundamental nature of modern capitalism. We are taught to envision markets as a simple exchange between the creator of a good and the consumer of a good. A farmer grows wheat, a baker bakes bread, a family buys the loaf. But the 21st century economy is rarely so direct. It is increasingly defined by the entities that position themselves between the creator and the consumer. This is the economy of the toll. The economic principle at play is profound and unsettling. When a market creates a massive, complex inefficiency, such as the wildly inflated cost of American healthcare, it births an industry dedicated to managing that inefficiency. But once that management industry reaches a certain scale, its primary objective shifts. It no longer wants to solve the inefficiency, it wants to institutionalize it. The PBMs were hired to cure the disease of high drug prices. Instead, they realized that the disease was highly profitable, and they built a business model that requires the disease to be chronic. If pharmaceutical companies suddenly slashed the list prices of all drugs to a transparent, flat rate, the PBM empire would collapse overnight. Their billions in spread pricing, their massive rebate retention, their steering of patients to vertically integrated specialty pharmacies, all of it depends on the existence of an artificially inflated sticker price. The intermediary does not produce the chemical compound that saves your life. The intermediary does not diagnose your illness. The intermediary does not physically hand you the bottle. They produce nothing but friction, and they monetize the easing of the very friction they help maintain. This is the ultimate triumph of the administrative state over the physical world. The patient, standing at the counter, sick and vulnerable, is no longer the customer. The patient is the raw material. The patient's illness is the data point that triggers the transaction, allowing the rebate to flow, the spread to be captured, and the margin to be recorded.
The health plan is the real customer, buying the illusion of cost control. The drug maker is the supplier, buying access to the formulary. The patient is just the conduit through which the capital is extracted. We built a system to protect ourselves from the rising cost of staying alive, and in doing so, we handed the keys to a cartel of middlemen who operate in the dark, accountable only to their shareholders. The mechanism is perfect. It is not broken. It is functioning exactly as it was designed to function by those who profit from its complexity. As the concentration deepens and the vertical integration tightens the grip of the 6 giants over 90% of the market, the physical reality of medicine becomes entirely subordinate to the financial reality of the intermediaries. You leave the pharmacy. You hold the amber bottle. You paid the $50. The drug maker got their cut. The middleman took the rest. And as you walk out into the light,
you have to ask yourself, in a system where the cure for high prices costs more than the medicine itself, who is actually being treated?